It should be realized that COPD is not a disease. Actually, COPD is a chronic respiratory disorder that is defined by the presence of a reversible and naturally progressive airflow obstruction occurring in the presence of well-known risk factors and in the absence of other convincing explanations, such as cystic fibrosis, chronic asthma, bronchiectasis, constrictive bronchiolitis, and so on. Thus, in the COPD acronymus, D should stay for disorder and not for disease. Therefore, the diagnosis of COPD must rely on the presence of both risk factors and obstructive ventilatory defect measured by simple spirometry and confirmed by the TFNO index below the lower limit of normality. The symptoms ascribed to COPD, either referred or not referred spontaneously by the patients, are not crucial for the COPD diagnosis, especially for an early diagnosis. This is, however, the beginning and not the end of the history. After the COPD diagnosis has been made, the first step is to establish the underlying prevalent lung disease, such as panlobular emphysema or more often chronic fibrosing bronchiolitis, alone or associated with some degree of centrilobular emphysema, mild, moderate, or confluent. All these conditions may or may not coexist with chronic bronchitis, as defined by the persistence of chronic cough and phlegm. This task must be done by clinical examination and complete functional and, if necessary, imaging procedures, because it is highly relevant for choosing both pharmacological and not pharmacological long-term baseline treatment of the patients. The second step is determining the severity of the disorders that should be performed by a multiparametric evaluation based on severity of symptoms, diurnal, nocturnal, at early morning, and degree of airflow obstruction, exercise limitation, nutritional status, and gas exchange abnormalities. This assessment is mandatory to establish the level of aggressiveness of the treatment that should be focused to control the most relevant patient-related outcomes, such as symptoms, tolerance to effort, quality of life, and to freeze or limit the functional decline of the respiratory function, according to what is allowed by the prevalent underlying disease. Furthermore, the most relevant comorbidities have to be carefully checked and treated accordingly. Such procedure is very useful to reduce all-cause mortality in COPD patients. Finally, the previous annual history of the COPD exacerbation must be collected, mainly focusing on the severe exacerbation, leading to hospitalization. And this exacerbation possibly should be phenotyped, because it is of paramount importance to implement specific treatment to prevent them. In their seminal paper, Fletcher and Pito described first the age-related lung function decline in terms of the FEV1% annual change, made 100% the reference FEV1 value at age 25 in susceptible smokers as compared to non-susceptible smokers and non-smoker subjects. Despite several limits, this study showed a faster decline in some subjects, the susceptible ones who developed COPD, that progressively increased in the more advanced stages of airflow obstruction. Although such a trend reflecting the functional decline of the respiratory function in COPD patient is correct, when the FEV1 annual loss is observed as percent change, the message inferred from the Fletcher and Pito diagram was that much of the therapeutic attention had to be paid in the late stages of this functional disorder. Recently, however, looking at the FEV1 absolute annual decline in the true placebo arms of the most relevant randomized clinical trials in COPD, published in the last 15 years, it was obvious that the greatest loss of FEV1 in average occurred in the gold stage 2 and much less in the gold stage 3 and 4 respectively. Being the absolute FEV1 changes more relevant for the respiratory function of the COPD patients than percent FEV1 changes, This finding might be crucial to modify the therapeutic approach to COPD, that from now on should be never delayed waiting for debilitating symptoms or severe airflow obstruction, but offered earlier, at least in the mild GOD stage 2. The corollary of this view is that the necessity of making the COPD diagnosis in the initial stages of the disorder, to implement an adequate treatment early in these patients. Benefits of this approach are likely, are suggested by the post-hoc subgroups analysis in the previous interventional arms of large studies on COPD, where improvement in FEV1 annual decline and all-cause mortality were demonstrated only for COPD patients in GOLD stage 2 and 3. However, this strategy must be definitively proven as effective by longitudinal studies properly designed for such primary aim.